for those of you that were here last week, you met Neda. I'm Jack. Neda's pretty much going to take it from here. So good to meet you.
Hi, Jack.
I will do some work at some point, don't worry.
That was Jack, everyone. Cool. So, how's everyone? Good. Awesome. Okay, cool. So, I hope you guys liked the abdo session last week. Today we're going to go over cardiovascular examination. Cardio is a good exam. It's a fast exam and one that you can do very quickly. I know your OSCEs are like 6 minutes, I think, right? 7 minutes. 8 minutes. Alright, cool.
Make sure you know how long it is.
So your OSCEs are probably what, 20 minutes by the look of it by then. So yeah, it's one to get done early and then you can really shine. So it's important to look slick because everyone knows a cardio exam should be quick. So you guys should be able to do that one very quickly. It will show if you're doing it slowly. And secondly, it's a chance to get it done out the way and answer questions. Cool. And so thank you all for doing the feedback last week. We did note it down. You guys said to go down a little bit slower. So I think last week was a bit fast because of the introductory stuff and going over like basics like blurbs and things like that. Hands up who was here last week. Okay, hands up who wasn't. Okay, cool. So I'll try and explain a couple of things that we talked about last time. But yeah, so that was, I think that's probably what took more time. Today I'm going to explain a bit more about the physiology and signs and things like that, which is again what other people wanted to know. And lastly, we're going to have a demonstrator. One person said they wanted a patient who was willing to take their shirt off. That person, you're an animal, and but Jack has kindly agreed to take his shirt off, so we'll do that. All right, cool. So, without further ado, cardio exam. So, in the spirit of demonstrating and things like that, who here has written a blurb? Yeah? Would you like to practice your blurb? Are you sure? Because you can read it if you like.
I haven't got it on me. I wish I could tell anyone.
Does anyone know? Like, would anyone like to have a go? Because I think it'll be good if you can say it in front of everyone here. It will be a breeze in the exam. Just the introduction up until. Can I have a look at your hands? Does anyone want to have a go? Brilliant, well done. What's your name?
Robin.
Robin, well done. Alright, Jack, jump on the couch. Alright, fine, very well. Okay, Robin, so the whistle's just gone, and you've opened the door, and I'll be the examiner and Jack will be the patient. Over to you.
Okay, hello, my name's Robin, and I'm a third-year medical student from King's College London. And today I've been asked to examine your heart, which will involve me looking at your hands, your face, and having a listen to your chest. Would that be okay?
Absolutely.
Okay, so just to confirm your name and age, please.
Yeah, it's Jack Faulkner, I'm 25.
Oh, it's lovely to meet you, Jack. For this examination, I'd like you just to take your shirt off, if that's okay. I'm going to wash my hands while I do this. So you can just lie back on the couch for me.
Okay.
And as I do the examination, I'll just be talking through some things out loud. If you don't understand anything that I'm talking about, please stop me and I'll let you know. Explain what I'm talking about.
That was really, really, really good. I liked as well that you said you would explain jargon as you went through. Really nice patient manner. Excellent. The only thing I would add to that is and I'm sure you would have, had you not had an audience of however many, but just to ask him about if he's in any pain.
Yeah.
That's so important. But yeah, all of you should make sure you ask about pain before any examination. And offer, I mean he's 25 so he probably doesn't need to, but you know, he might have a busted shoulder and not be able to take his shirt. So just ask if he needs any help in that respect. And I always said the examiner would act as my chaperone, just to cover your bases. You don't need one in a cardio exam, but if it's a woman, they will be taking this off as a guy examining. It's always better safe than sorry. But really, really well done. Okay, cool. So everyone just keep writing blurbs. Like make sure you've got your patter down so that it can roll off the tongue without even thinking about it. Because you don't want to be thinking, oh, I've asked for his date of birth. Now I've asked if he's in pain. Now I've gained consent. It should just be what you say at the beginning of every examination. Good. So what do we say was the most important part, what I thought was the most important part of an examination?
To the bed examination.
Sorry?
The general observation.
Very good, inspection. Okay, so there's some of them here. So we've introduced ourselves. Jack is now at 45 degrees, so not flat. He's at 45 degrees for a cardiovascular examination. He's got his shirt off, he's not in pain, and I've washed my hands. The examiner's there, so I said, hi Jack. My name's Ed, I'm one of the junior doctors, blah, 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 blah. I'm just going to have a look at you from the end of the bed. Just lie back comfortably, and it'll just take a moment. Sorry if it looks like I'm staring, okay? So, what are some of the things we're looking for around the bedside in a cardio exam?
GTN spray. GTN spray.
GTN spray, very good.
Oxygen.
Oxygen, excellent.
Walking aids.
Walking aids, yeah. Okay, fine. If they're an older person, they've fallen over, fine. Very good, yeah. Salbutamol, yes, more so for a respiratory examination.
ECG leads.
Yes, excellent. ECG leads. So that's an ECG machine, and this is a cardiac monitor. So that's another one. So if they're on certain medications, they might need to be monitored continuously. It's usually in HDU. They don't normally have them on the wards, but that's the kind of thing you're looking for. Someone said GTN spray. So around the bed for any medications, GTN, any other medications that might be cardiac in nature. Okay? And then I always, yeah, what else? What else? What about on Jack himself? His breathing as a sign of how comfortable he is, how unwell he is. Very good. Who said so? Yeah, very good. What's that a sign of? Excellent. Did everyone hear that? Mitral stenosis, okay? We'll come on to that. But very good. Anyone else? Scars. Okay, whereabouts would you expect to see some scars? Sorry? A pacemaker scar. So up here, just under the clavicle, just under the clavicle there. Anyone else? Yeah? Okay, yeah, thoracotomy. Who said midline? Someone said midline. Excellent. What would you be expecting?
Cabbage or aortic valve replacement.
Very good, very good. Did everyone hear that? So the two you're looking for with a midline scar, I'll bring them up actually. So, this is a midline stenotomy. Okay, so they've essentially opened up his sternum, cracked it open, and operated. So, just judging by looking at that, you are thinking of a coronary artery bypass graft or a cabbage, okay? Or, as you correctly said, a valve replacement. So those are the two you'd be thinking of. So what if they had this scar as well? The scar that says Science Photo Library. Who said that? Yeah? Yeah, very good. So sometimes they can take veins from your arm or from your leg, okay? Yeah, so that's how they form the graft. They take a vein and they essentially rewire the coronary artery so that you can get more blood supply to the muscle. So what I always do when I'm inspecting at the beginning of a cardio exam, so I've looked around the bedside and then I say, okay Jack, would you mind just popping your hands up like a chicken? Good. I'm going to have a good look at the sides, as you said, like thoracotomy scars. I'm looking at the midline as well. I'm checking if he's got a pacemaker scar up here under the clavicle. And then I say, can I just roll your trouser legs up? And I roll each leg up. You're not in any pain while I do that, no. Roll them up and look on the medial aspect for vein harvesting scars. Okay? These are the sites where you're looking, alright? Good. Any questions so far? Yeah.
Sorry, can you just switch the bed so it's like facing us?
Yeah, so who can't see? So, like this?
Yeah, as in, can you do it like facing this way?
He'll only be facing.
No, as in Okay.
As in, you always examine from the right
So you
side.
always, yeah. I'll be now, so that was inspection from the end of the bed, and now I'll be performing the exam from the right-hand side.
Okay, I just meant that as in put the head back, the feet here, so everyone
Oh,
can see.
like this way.
Yeah.
Okay.
That's like what we see it, so that's fine. That's like what we see it.
Oh, they would. They would if it's.
Let's just do it like this. How's that?
How's that? You guys can't see anything, but it doesn't matter. Okay, everyone on this side happy? No, can you see? Okay, do you want to maybe everyone on this side?
Sorry, I didn't think of that.
Okay, cool. Let's put it back to the middle. I think you'll be able to see once I come round.
Just do it a little. Don't still leave that.
But how about we just? Okay, yeah, fine. All right. Good. So up like a chicken, close. Have a look at the sides of his chest, in the midline, and his legs. Very, very important to roll the trouser legs up, okay? Because that's big indicator. Say they don't have a scar on their arm, and they've just got a midline scar. You're like, cabbage, valve, cabbage, valve. Roll up his legs, I know if he's had a cabbage or not. Easy? Okay. That is what a pacemaker will look like in someone who's fairly thin. Can everyone see? Is the light too bright? It's like, and when you come onto palpation, you'll feel the lump just there. Okay? Good. What am I looking at here? Edema, you don't know if it's pitting or not, but yeah. So, peripheral edema. What would that indicate to you in a cardiovascular examination? Heart failure, excellent. More specifically, which side?
Right side.
Very good. Right side, did everyone hear that? Someone else in the feedback said to repeat everything that anyone in the audience said so they could hear. So, right heart failure. Okay, now, big part of a cardiovascular examination is in the OSCE, your head is going to be 1,000,001 things are going to be going on, okay? Just stop and just say, so I looked at the end of the bed. Most of the time, it will be so silent in that OSCE that you should be able to hear the click of a metallic heart valve. Okay? Might be difficult on a ward, right? But don't put anything to chance. So when you've had a look at it, if you can't hear it, it's literally like a clock ticking. Does anyone here, hands up, who's heard a metallic heart valve? From the end of the bed? Yeah? Okay. If you hear that, that is gold. That is absolute gold in your OSCE, because now all you have to do is remember your blurb for presenting metallic heart valves. The rest of it is just a doddle, because you know what's going on. That's why this part is so important. You can figure out so much from the end of the bed. If not, you can literally come up to me. Okay, Jack. So I'm just going to have a quick listen to your chest. Okay, just with my ear. So you just breathe away normally. Okay, and then really get close, and you should hear a tick, tick, tick. Okay, it's literally like a second hand of a clock. Okay, so that will be in a metallic heart valve. But if they've had a tissue heart valve, you won't hear it. You won't hear the click. Okay? So if they've had a midline stenotomy and no other scars, they may have had, and there's no loud heart sound or clicks, it may be that they've had a tissue heart valve replacement. Does that make sense? Very good. Okay. So an important thing now, oh wow, it's really fast. Okay. An important thing, that's fine, we'll slow down. An important thing to remember about metallic heart valves is the complications of a metallic heart valve. Okay. So we said that. So you see the scar, and bless you. You see the scar, and you can hear a click. And so now you're looking to make your presentation super slick. Is you're now looking for the signs of complications of heart valves. Okay. And there's two acronyms you can use: Be Fast or FEBAT. I prefer Be Fast because what the hell is FEBAT? But whatever. Does anyone know the complications? Let's open up first to the floor. Infection. Very good. Like any heart valve, they're actually more susceptible to infections, especially because it's an invasive procedure as well. You can get infections. What else? Anyone else?
Thrombosis.
Very good. Very good. Thrombosis, yep. So that's more infection. Yeah. But a better way of saying it. So good. Anyone else?
Anemia.
Yes. Anyone else? No. Bleeding. Very good. Okay, so we'll go through them. Okay. So the F is failure. Okay. So when you put in a valve or any complication of any surgical procedure, ultimately one complication is that it fails. And so if you put in a heart valve, for example, they may still have stenosis, they may still have regurg if the valve is not the right size, or for whatever, or if it's not the right size, or various other complications of surgeries can result to the procedure itself failing. Okay, and failure also therefore can stand for heart failure, because you may have a leaky valve causing heart strain, causing heart failure, and once you've replaced the valve, you'd like those symptoms to ease up, ideally, right? So, if that fails, then they may still be in heart failure, or the valve itself is failing. They still have stenosis, they still have regurgitation. Okay. A is anemia. So metallic valves, as the blood goes through them, there's an increased chance of hemolysis, so red cells being broken up as it goes through as they flow through this metallic valve. Okay, so this anemia, you'll get a breakdown of your red blood cells. So you're anemic, but you may also get an increase in bilirubin. Yeah, so you may actually look jaundiced, because when you're breaking up more of your red blood cells, you're producing more bilirubin in the spleen, and that might actually they may actually get jaundice from it. Okay, so anemia and jaundice. S or I is sepsis or infection. Yeah, so you're looking for signs of infective endocarditis. Basic things like temperature are the first things to look for. So temperature spikes, but then also the other signs like splinter hemorrhages, Osler nodes, Janus lesions, which we'll come to. Okay. Thrombosis. So again, you're at increased risk of producing clots that get thrown off. They may be thrown off, and you get PEs, DVTs, strokes, that kind of thing. Okay. So which is why anyone on who has a metallic heart valve has to be on which drug? Warfarin. Excellent. Okay. So another complication of that is then therefore bleeding. Very good. So a lot of the time you'll see a patient with a metallic heart valve, you'll hear the click, you'll see the scar, and you'll see they've got bruises everywhere because they're on warfarin, and that's a complication. Okay, so that's something to add into your presentations at the end. So I heard a metallic click with a loud heart sound, blah 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 blah, which we'll come to at the end. There are also signs of complications, namely bruising in the arms, and this may be due to warfarin therapy, etc. Okay, the target INR, maybe this is too much, but the target INR for a metallic heart valve is 3 to 4. Okay, but for atrial fibrillation it's 2 to 3. Okay, so again, that's another thing to look for around the bedside. They have a yellow warfarin book. Sound good?
Sorry, is that the target or what they actually have?
The target. Target, yeah. If it's lower than that, you'll need to adjust their warfarin, or if it's higher, you want it to be between 3 and 4. Okay? So be fast or be bad. Okay? So when you hear the click, immediately start looking for those extra things, okay? Cool. Am I going too fast, too slow? Everyone put your hand up because I'm going too slow and I'll slow down, okay? So like we said, any examination, you start at the hands and work your way up to the face, into the neck, into the face, chest, and down. Okay? Every examination. So if you get stuck to what's the next step, just follow that path. Okay? So, What am I looking for in Jack's hands?
Osler node?
Very good. What is an Osler node?
Well, it looks a bit a little red circle.
Okay, yeah. Anyone know what an Osler node is?
It's like septic envelope.
No, that is a splinter hemorrhage and Janeway lesions. Okay, splinter. So I'll pull out the picture. So Osler nodes are painful immunocomplex deposition in the finger pulps. Okay, and the way I remember it, which one's which, is Osler, ow, so that hurts. Okay, so Osler nodes make you say ow, it hurts, oh, oh. Janeway lesions and splinter hemorrhages don't really hurt. Okay, and Janeway lesions and splinter hemorrhages are hemorrhagic thromboemboli that are thrown off, and they cause these little painless small hemorrhages. Okay, and what are they a sign of? Bacterial-infected endocarditis. Okay, so again, when you're speaking to your examiner, you're looking at the hands. You can say, I'm looking for clubbing as a sign of congenital cyanotic heart disease, which is very rare, and atrial myxoma. Like we said, you're always going to say the signs you're looking for and explain what you're looking for, why you're looking for them. You're not just going to list off a load of signs that you're looking for in an exam, right? You're just going to, so you're going to, when you write your blurb, so everyone write blurbs, so we can do, was it Robin? Yeah, so we can do what Robin did next week. Cool. So I'm looking for signs of infective endocarditis, namely Osler nodes, Janeway lesions, and splinter hemorrhages. And any other signs in the hands that anyone's thinking about? Yeah. Very good. It's tar staining. But yes, very good. Same with conjunctival pallor and anemia. Just make sure you know what you're saying, but you're right. Very good, along the right lines. Anyone else?
Small muscle wasting.
Okay, why?
Muscle weight.
Okay, in a cardio exam? Very good. We're talking strictly OSCEs. As a doctor, excellent. But in a cardio, more RESP. Why RESP? Which cancer? Very good, a pancreas tumour. So it's an apical lung tumour, called a pancreas tumour, and that can press on your brachial plexus, and it causes nerve damage. And don't write this down, we'll go through it next week, don't worry. And that will cause muscle wasting in the small muscles of your hand, okay? So good, but in this exam?
Xanthomata.
Yes, very good. What are they?
Is it like little yellow like things that you find on your digits, and it's a sign of hyperlipidemia?
Yeah, hypercholesterolemia, yeah, very good. So tendon xanthomas, so cholesterol deposits on the tendons, usually down on the elbows and the forearm, but yeah. And then we'll get to them around the eyes, xanthelasma, like we said. A big thing is how the patient feels. Are they cold and clammy? Are they sweaty? If a patient looks grey and sweaty and says, ow, my chest, I'm worried, okay? If they're cold and pale and peripherally shut down, I'm worried. Their blood pressure might be low, they might be in shock, okay? So obviously you're not going to get anyone in shock in an OSCE, but these are things to look for, okay? And if their fingers are blue, yeah? Might have poor circulation to the fingers, periphery, okay? So, and capillary refill time. That's very, very important, all right? Again, a sign of perfusion to the limbs and blood pressure. All right. So yeah, if their fingers are blue, they might be periphery very cold. This is, as you correctly said, tar staining of the fingers, which is a sign of smoking. Why is everyone whispering? What? Smoking, yeah. Cool. And capillary refill time. So we'll get on to pulse in a sec. So what you're going to say is, okay, Jack, so as I said, I'm just going to have a look at your hands. So would you mind placing your hands in mine? Good. I'm just going to have a quick look at your fingers. Okay, that's fine. I'm going to press down on your nail bed, okay? It shouldn't hurt, but if it does, let me know. And you press for 5 seconds. And it should fill back in less than 2 seconds. That's normal, okay? Good. Okay, Jack, and can you turn your hands over for me? Good, and I'm feeling if he's cold, if he's sweaty. Alright? Good. And now can you pop both hands out straight like that for me? Okay, I'm going to feel both your pulses. And you feel both pulses at the same time. Okay, why am I feeling both pulses? What is that a sign of? Coarctation of the aorta, but I mean, yes, in an aortic aneurysm, depends where. If it's, oh, now you're testing me. If it's between, it's rare, but if it's between the where the two subclavian arteries come off, then yes, you'll get a delay, but that's very rare. It's a small part of the aorta. Mainly get it in the descending aorta, okay? And if it happens in the ascending aorta before they bifurcate, then you won't get a delay. But it's for coarctation of the aorta, okay, which is a narrowing in the aorta. So there's a delay as the blood rushes up the aorta out to the two subclavian arteries that go to your arms. There's a delay, so you'll feel like boom, 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 boom. Alright? Good. So, now, oh, and I forgot to say, splinter hemorrhages, if they're at the tips of your fingers, if they're like down here sort of thing, they can be traumatic as well. So if someone loves gardening, someone like does heavy lifting, whatever, sometimes if you look at your fingers and you hit your hand or something, you'll get a small splinter hemorrhage. Okay? But if they're here at the nail bed, up here, or within the nail itself, that's the sign. Okay? Cool. So, I'll talk through this and then demonstrate it, okay? So, with the pulse, you're looking for the volume, character, the rhythm, and the rate. Okay? So everyone's going to be wearing a fob watch, and you're going to have to time for how many seconds? 15 seconds, and then we're going to times it by... Excellent. And if we're going to make it up, it's going to be a number divisible by... Very good. Yeah, okay, so we feel the radial pulse. We feel for radio-radial delay, as I showed you. Radio-femoral delay, which is again a sign of coarctation. Okay? The brachial pulse. Check for collapsing pulse. And then we check the carotids. Okay? I'll demonstrate that now, okay? So, okay, sir. So, can I put your hands out straight for me? Okay, very good. So I'm going to feel for radio. To make it look slick, you need to practice this, okay? I'm just going to feel both pulses at the same time. Good. I don't need to feel this one for 15 seconds. There's no delay. Pop this one down. Start timing 15 seconds. Okay. I've got the rate. I've assessed the rhythm. So if it's irregular, irregularly irregular, or regular. Irregularly irregular is a sign of atrial fibrillation. Regularly irregular might be like boom, 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 ba-dum, boom, 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 ba-dum. You see, so it's it's not normal, but it's staying the same. Hold my hand. It's staying the same, and that might be a sign of ectopic beats. Okay, and then regular is regular. Okay. The volume and character is best assessed at the carotids, okay? So I felt both here. Okay, so now I just need to feel one of the pulse in your groin. Okay, so I'm just going to find out feel for where it is, and then I'm going to measure the pulse in your hand and the groin at the same time, okay? So, who knows where the femoral artery is? When do you guys do anatomy? Huh? Okay, so the femoral artery lies in the mid-inguinal point. Did you know that? No? No. The mid-inguinal point. It's different from the midpoint of the inguinal ligament. Okay? Mid-inguinal point, okay, is from your anterior superior iliac spines, yeah, to your midline. It's easier to remember it as the midline rather than the pubic symphysis, because then you're like, oh, is it pubic symphysis or tubercle symphysis? Just remember it as acis to midline, and then halfway between the two. Alright? Midpoint of the inguinal ligament is from your pubic tubercle, and you've got two, and they're just inside, or just outside of the midpoint, of midline, sorry. You've got your midline down here, and your two pubic tubercles are just there. So it's just slightly different, but the ligament connects from bone to bone. Okay? Fine. So I'm just going to feel in your groin for the midpoint and the bony, and for your hip. All right, and then feel the midpoint. Feel where his femoral artery is. Find the pulse and go, okay. And now I'm just going to feel your wrist as well.
That happens when you examine.
Yeah. That's going to go off every time I do something wrong. Okay. Feel for radiofemoral delay. And go, okay, so now do you have any pain in your shoulder? Okay, I'm going to raise your arm above your head and then lower it slowly, okay? If you feel any pain in the shoulder, let me know. Alright? So you're from here, you go here, support the weight of the arm at the elbow, and you can even feel the brachial pulse here as well at the same time. So feel for the brachial pulse. Got it? Okay. And then raise the arm up slowly. And what am I checking for here? Okay, so the proper way to check for a collapsing pulse, all right, is now that it's up here, it's also called the water hammer pulse. And go, okay, sir, now I'm going to lower it slowly. You may feel it sort of collapse away and get weaker, but the proper sign for it is when you lower it slowly, it'll get to about here, and then it'll go boom, 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 and you'll really feel it get stronger at your hand. And that's what you're looking for, okay? You're not looking for it to sort of collapse away here. It's as you lower it down, you're feeling at the radial, and it's getting stronger, okay? You've assessed the brachial pulse as well at the same time. Okay, sir. Now I'm going to check for the main pulse in your neck, okay? Might be a bit uncomfortable, and if it is and you want me to stop, I can at any point, okay?
Yeah.
So yeah. The collapsing pulse, sorry, it's a sign of aortic regurgitation. Okay? So as the aortic valve is leaky, blood sort of falls back into the ventricle, and the pulse is sort of getting weaker as it falls. As you raise the arm, the effect of gravity on the weak aortic valve, that whole column of blood is harder for it to shoot up, and more falls back through the leaky aortic valve. Yeah, so blood's going up, but because of gravity, there's more pressure, so it falls back. Make sense? Any questions? Okay. Yeah, we'll wait a sec. But do all the pulses first. So then, and now I'm going to feel for the main pulses in your neck. Okay. So the easiest way to find the carotid pulse, a lot of times it's really, really difficult, and you're like sort of pressing on the windpipe, and it's like it's not really working. Just find the angle of the jaw. Yeah. And then just take two fingers and just go just underneath it and press. Can everyone feel it? Everyone try it. Don't feel both at the same time or you'll pass out. Yeah? So don't worry about sternocleidomastoid and the windpipe and where am I going. Just find that bony angle of the jaw and then put two fingers just underneath it. Alright? Anyone having problems? Okay, cool. So I feel this side, and I can assess if it's got a good volume, good character. And I'm going to feel the other side as well, sir. Excellent. And now if you could look over to your left-hand side for me. And now I'm going to assess the JVP. We'll talk about that in a second. Alright? And have a good look. Very good. And then turn to your examiner and say, at this point I'd like to take the patient's blood pressure, would you like me to do so? He'll say no, carry on. Alright?
So, which of the factors when we're measuring the pulse can you not determine from the radius?
The volume and character.
Okay.
it's better, it's more clear at the carotid.
Yeah.
Rate and rhythm is easier at the radial. Alright? Do you want me to do that one more time? Just so to see it top, or is everyone happy?
Can you do it again on?
Yeah, that's what I mean. Do you want me? Yeah? Everyone want me to do that? Oh, Jesus. Okay, fine. We'll do it very quickly. Okay, so now I'm just going to feel for the pulses in both of your arms, and I need to feel for a pulse in your groin. Okay? So I'm just going to feel in the midline for a bone, and then your hip bone as well, and I'm going between the two. Is that okay?
Mm-hmm.
Fine. So can you pop both your arms out like this? I'm just going to feel both pulses. Okay, you can rest that arm back down now. I'm going to just time it for 15 seconds. 15 seconds. Okay, and now I'm just going to place your arm down, feel for the pulse in your groin. Feel it here, feel it here. There's the pulse. Okay, I'm just going to feel the pulse now in your hand. Okay, very good. And now, do you have any pain in your shoulder at all? No? Okay, I'm going to raise your arm up very slowly above your shoulder, and then I'm going to lower it down slowly again. If you feel any pain, let me know. Alright? Feel the brachial, feel the radial. Okay. And now I'm going to lower it slowly. Very good. Now I'm going to feel the main pulse in your neck. So I'm just going to place my hand on your neck. It might be a bit uncomfortable, okay? Find the angle of the jaw. Okay, and now on the other side. Good. And now, would you mind looking over to your left-hand side for me? Great. And turn back to me. Thank you. At this point, I'd like to take the patient's blood pressure. Would you like me to do so? Done. Okay? It won't take long. It's just long to explain. But that's a slick way of doing it, okay? Check all the pulses, check the delay. It doesn't take long. Check, yeah. Yeah, I've never really understood it, but it's always... Volume is obviously how strong you're feeling it. Character is if it's a thready pulse, if it collapses, things of that nature. Yeah? Agree?
Yeah, things like slow rising pulse and things.
Okay. Cool.
What does slow rising correspond to?
Aortic stenosis.
So the positions of the pulses we talked about. Everyone take your wrist and cock your wrist back like that. Okay. At your thumb side, that's the radial side. Can you feel that tendon? Yeah. Can you feel a tendon just there? Okay. Now go lateral to it, outwards. That's where your radial pulse is. Okay. So whenever you're doing it on a patient, just go to the outside of that tendon, and femoral pulse we talked about. Okay. Good. So now we've asked for the blood pressure. Okay. So you're looking for high blood pressure. It's not going to be a low blood pressure. It may be, but it'll be arbitrary. They won't actually have low blood pressure, and they won't be hemodynamically unstable in your exam. And the pulse pressure, that's an important one. This one could give you the diagnosis straight away. There's a difference. It's the difference between systolic and diastolic. Okay, makes sense? So, a low pulse pressure, so the difference isn't much. It can happen, sure, in heart failure, in shock, in tamponade, fine. But the one you're looking for is aortic stenosis. Okay? So when the difference isn't that much, that's because the systolic blood pressure is often reduced. Okay? Because you can't get that much blood essentially out of the aortic valve. Where, yeah, that's right, yeah. Well, anyway, low pulse pressure is aortic stenosis. For wide pulse pressure, this is a gift. If he tells you, oh, the blood pressure is 180 over 40, you're like, okay, well, he's got regurgitation. Okay? It's easy. It can happen when you've got stiff arteries, like atherosclerosis, and it also happens when you've got thyrotoxicosis, so hyperthyroid, when you're hyperdynamic. Okay, so in pregnancy, your stroke volume, your circulating volume is increased. Thyrotoxicosis, your cardiac output is increased as well. And anemia, your heart cardiac output increases as well to compensate. So you'll get wide pulse pressures. But in the exam, the one you're looking for, if it's really wide, is aortic regurgitation. Okay? Cool. JVP. JVP. From the sternal notch, which is at your second rib, so if you run your hand down your sternum, okay, there's a little bump Yeah? Can everyone feel that? Go from top to bottom, there's a little bump. That level is at your second costal cartilage. Alright? From that point, straight down to your right atrium is 5 centimetres. So, when they don't really talk about it in this way on the wards normally, but technically speaking, the JVP will total venous pressure, or central venous pressure. When you give the number, it's the total. So you minus 5, and that'll be how many centimetres it's raised from that sternal angle vertically up. Okay? Let me explain. So Jack's lying down. I can see a biphasic pulsation in his neck. I think it's his JVP. Alright? So I look from his sternal angle here. How many centimetres up do I think it is? Okay? So it's like probably about 3 centimetres. The total will be 8. Does that make sense? Yeah? But you can just say it's raised by 3 centimetres. You don't have to talk about central venous pressures and things like that. Another thing to think about with the JVP is sometimes it's not easy to tell if it's JVP or if it's carotid artery. Do you have a question? No? Okay. If it's carotid artery or if it's JVP, right? You're seeing like a little flicker in the neck. Is it, isn't it? So he's looking over to his left-hand side. He's relaxed back. Carotid artery is a clear, monophasic, if you like, pulsation. Yeah? Boom, boom, boom. JVP is like a little flicker. It's biphasic. Okay? So it's like I don't know. It doesn't look like a forceful pulsation. It's just a little flicker in the neck. That's the first thing. Secondly, don't forget to look all the way up until the ear, because it could be right up by the ear and even behind, so you'll miss it. Okay? And thirdly, and the carotid wouldn't be up there. Alright? Thirdly, is it occludable? Is that the word? Compressible. If I compress the artery or the pulse, does it go away or not? If it doesn't go away and I can still feel it, and I can still see it in the neck, that's the carotid artery. If it goes away, that's your JVP. Okay, so those are the 3 things you're looking for. Does that make sense? Am I going too fast? There's a lot more info this time in terms of pathology, but someone wanted to explain more of the signs, so hopefully that explains it. Okay, cool. This is your JVP. This is your waveform. Don't worry about it. You can learn it if you really like, and it might come up in one EMQ, and you'll get it right, and it probably wasn't worth the hour you spent learning it. Okay, you can probably guess, but that's poor medicine, so you should learn it. But anyway, so I wouldn't worry too much about it. But it's essentially there's no valves in the vein from your tricuspid valve all the way up. Okay. So it's essentially like one column of blood. So that column of blood reflects all the differences in pressure in your heart. You can see it. Okay? So the first flicker will be atrial contraction. Okay, then it will dip. Then you see your second one is when your atria fill up passively. The pressure will increase. Or there will be a backlog of pressure up the column of blood. Okay? And when the atrium contract, again, backlog of pressure. That's just what it is. Just to have an idea, okay? X descents, Y descents, you can learn it if you like. We won't go through it today, but that's the why it's a double flicker, okay? Good. Now we're on the face. What signs are you looking for in the face?
Corneal arcus.
Yes. Again, we talked about it last week. Very good. Cholesterol deposits in the eyes. Anything else? Dantelasmas again, we talked about that one, very good. Conjunctival pallor again, yeah. Yes, very good, as a sign of Marfan's, which, you know what I'm trying to ask you, what is the valvular defect that you get regurgitation, yeah? Because aortic regurgitation, the causes can be valvular or to do with the aortic root. So when in Marfan's you'll get it's a connective tissue disorder, yeah, where you get very tall, high arched palate, many other signs. But if you get a huge guy, really tall, he's like 6'8", he's massive, got a high arched palate, he'll have a mid-diastolic murmur. That's why they put him in your cardio exam. He's got a wide pulse pressure. Okay. So even if you say I couldn't hear a murmur, but he has other evidence of regurgitation, namely a wide pulse pressure, I'd like to confirm it with an echo, and he also has other stigmata of Marfan's disease. That's fine. Okay, you don't have to have heard the murmur. Okay. What's this? Why have I put this picture up? Central cyanosis. Very good. I'll talk about this very briefly, but in aortic regurgitation, it's always a lot of med students do it. It's fun to just learn all the eponymous signs of aortic regurgitation. Does anyone know any? Eponymous signs just means it's named after something. Yes?
Is it the
Demussets, yeah, what is that?
Is that when your head knocks with the beat, with your heart?
Yeah, with the beat, yeah. So you'll get head nodding with the carotids. Okay, it's just like this. And they're just like, what are you nodding at me for? It's very, very subtle. Alright? Anyone know any other signs? No? Okay, so the whole list. So, ones in the face that you might be able to see. In the mouth is pulsation of the uvula. That's Mueller's sign. Okay? They're all very rare, by the way, so don't worry if you can't see them. They're all very, very rare. Even if people have florid aortic regurgitation, they might not have them, okay? And there's different signs. There's Corrigan's sign, where you can see the pulsating carotids just from the end of the bed. Quincke's sign, where you can see it's pulsating nail beds, okay? You can see the blood pulsating under the nails, okay? That, just to give you an example, that is so rare that a video of it on an iPhone got published. Okay, like a journal accepted it and put it on their site and put a link to it. So it's so rare. We saw a video of it in Jack and I's lecture. Okay, it was such a shoddy video, but because it's so rare and that someone managed to film it, it got published. Okay, so don't worry. But again, you could be looking for that in the hands. It's academic. If you learn them all, it's very good. It's always fun to learn them, but don't get too bogged down. And then, as we said earlier, a malar flush and mitral stenosis in the face. All right? Good. So we've done inspection. See, all of that was just inspection, and we spent about 50 minutes just doing inspection. So much to pick up on inspection, okay? Palpation. There's not really percussion in the cardio exam. That's why it's a bit quicker. Palpation. So, Jack, would you mind taking your shirt off?
Still waiting for this. So late.
Yeah. Okay, and just unline the nose. Okay, so, yeah, I'm flustered now. Okay, so palpation. So the first thing to do is feel for the apex beat. Okay, apex beat in a dilated ventricle can be displaced. Not a hypertrophied ventricle. Hypertrophied ventricle, you might feel a palpable heave. But in a dilated ventricle, which you can get in things that cause aortic regurgitation, for example, it will be displaced. So it will be displaced laterally. So the way to do this again is go, excuse me sir, I just need to now feel for your heartbeat. Sorry if my hands are cold. I'm just going to feel down your armpit and then move round, and I'm going to count down to where that is from your ribs. Okay? And you feel right down here, sorry, right down into the axilla. Okay? Can I feel anything? No, no, come round, come round, come round, come round. I feel it there. Okay? Alright, so now I'm just going to count down. The clavicle lies over the first rib. So feel for the clavicle, and then straight away underneath it is your first intercostal space. Okay? Alternatively, you can feel for the sternal notch, and that's at your second rib. But the clavicle is much easier to feel. First space, feel the rib. Second space, third space, fourth space, fifth space. Oh, what a coincidence. Okay? It's in the fifth intercostal space, mid-clavicular line. Okay? That's where your apex beta is. Okay? So that's where it should be. So if it's displaced, you can count down, and if it's down here, or out here, I'll count down, and I'll see it's mid-axillary line, for example. Okay? So you just count down, feel where it is. It's there, so I feel for the apex B, and then I say, okay, sir, I'm just going to feel the chest, like that, and like that, for any palpable heaves or thrills. Okay? Anyone know the difference between a heave and a thrill? It feels like a vibration. What is it? Palpable murmur. A thrill is a palpable murmur, and a heave is a sign of hypertrophy of the ventricle, and you'll feel it as like an abnormally large beating in the chest. Okay? Whereas a thrill feel like a little vibration. Now, this is a big thing. You get to this point and you're like, how do I feel that? Like, and I had it in my OSCE, didn't expect it, didn't see it coming, bra was already off, and I said, would you mind removing your gown? And she just went, boom. Didn't have time to think. I was like, alright, here we go. Okay? So, half the people in this room have boobs, it's normal, just be absolutely normal about it. Don't get nervous, don't fumble. There's two ways to do this, especially in older women who have larger boobs, pendulous boobs is the word, where they might be down here. Okay, there's two ways to say it. Okay, so I just need to feel for your heartbeat. Would you mind just lifting your breast up so I can feel underneath it? Thank you, Mrs. Faulkner. I'm just going to lift your breast up with the back of my hand for a moment so I can feel for your heartbeat. Just say it normally, okay? Never with the palm of your hand, and never by the nipple. Ever, okay? That's a point I thought I would make because a lot of people, I've seen it. I was teaching the other day, and I saw a student go, so, like, do you want me to carry on, or like, what do you mean? Like, keep going. And he's like, okay, so 1, 2, and then obviously I'd get to 5. I was like, well, go on. Right? So it's just be confident, be normal. I think it's a point to make, okay? Ask them to lift the breast out of the way, or use the back of your hands, okay? And the easiest way is to count down along the sternum. Don't count down mid-clavicular line. You can see where mid-clavicular line is. There's no need to, like, run your fingers down the boob, okay? Just down the sternum, on the side, figure out where it is. You've got your hand there. Okay, that's mid-clavicular, okay? Right. And now, finally, auscultation, okay? There are different areas to listen to the different valves, okay? So here, over the apex, 5th intercostal space, mid-clavicular line, is the place to listen to the mitral valve. Okay? 4th intercostal space, tricuspid, parasternally. On the left, parasternally. And then you've got your 2 second intercostal spaces, right and left. It's the opposite of the way you think about it. On the left is the pulmonary valve, and on the right is the aortic. Okay, and they're called areas. The aortic area, pulmonary area. You can call them areas, or you can say, I heard a harsh ejection systolic murmur heard loudest at the right second intercostal space parasternally. That is the best way to say it. Okay? And mitral valve murmurs, or mitral regurgitation, actually all mitral valve murmurs, the murmur will radiate down into the axilla. Okay? And aortic valve murmurs, regurgitation will be heard loudest this way, because the blood the blood falls backwards this way, or stenosis may radiate up into the carotids. Okay? So you know where the apex beat is, You know where you're listening for your mitral valve. Now you can get your stethoscope out. Okay? And this part is the slickest part, is the easiest part. And this is, you can do this one, this bit very, very quickly. And I'll show you how to do it and make it look slick like we did with the pulses, okay? So, where's my step? Does anyone have any questions so far? Am I going too slow or too quick? You can say it.
Faster's not a problem.
You want to go faster? Okay.
That sounds like a now.
Is everyone happy to go faster, or is the current pace okay?
Keep it the same, keep it the same.
Keep it the same.
Go fast.
Because there's a lot to take in cardio.
I
Okay.
appreciate faster.
Faster. Okay. All right. So moving back to. I'm just going to feel for your heartbeat now. Okay. I'm going to move my hand into your armpit and move it round, and then count down across your chest to figure out where it is. Okay. Sorry if my hands are cold. There it is. Good. Okay, now I'm going to have a listen. I already know where I felt the heartbeat, so I can put my stethoscope there. I don't have to count it down again. And now while I listen, I'd like to feel the main pulse in your neck. Okay? If it becomes too uncomfortable, do let me know. Okay? So traditionally you listen over the mitral area with the bell of the stethoscope. Okay? And you're feeling the carotid at the same time. Fifth intercostal space, mid-clavicular line. Fourth, and then switch it. Fourth intercostal space, on the left parasternally. Second intercostal space, left. Right. Back to the apex. Okay, sir. Now what I'd like you to do is, are you able to roll over onto your left-hand side for me? Okay, can you do that? Okay, that's it. Axilla. That's fantastic, thank you very much. And can you take a deep breath in for me? And all the way out. And hold it there. And relax. Okay, and roll back towards me. Good. And now can you lean forward for me? Take a deep breath in. And all the way out. And hold it there. Third intercostal space. And relax. And now what I'd like to do is listen to the main arteries in your neck. So take a deep breath in. And hold it there. And relax. Take another deep breath in. And hold it there. And relax. Okay, and now take a couple of deep breaths in and out through your open mouth. And out. And again. Do you have any pain in your back at all? I'm going to press lightly on the small of your back, okay? Let me know if it hurts at all. 2, 3, 4, 5. That's fine, and relax. And do you have any pain or swelling in your ankles that you've noticed? Okay, his legs should already be exposed. I'm going to press down on your ankles for 5 seconds. 2, 3, 4, 5. Perfect. Thank you very much. That completes my examination. Do you have any questions at all for me? Okay. Do you need any help putting your shirt back on? I will. Thank you very much, sir. I'm just going to turn and speak to my examiner now. Okay? You take your stethoscope off, put your hands behind your back, and you never look back. Don't ever look back at the patient. Cool. Was that clear? Did it look slick? Thanks. Okay? So we went through it. So those were the steps, okay? That's the best way to do it as well. You are. See you later. You want to get them rolling to their left. You don't want to get them up, then down, roll back. Especially if they're old, you know, it can be difficult and time consuming. You want to do the steps in the quickest way possible. Yeah? So you need to get a patter, and that's probably one of the best ways to do it, in my opinion, the best way to do it. Okay. The breathing exercises. So, murmurs, I'll get onto that in a sec. I remember it by Ryle. Okay? Right-sided, inspiration. Left-sided, expiration. Right-sided murmurs are heard loudest on inspiration. Left-sided murmurs are heard loudest on expiration. Okay? So, and it's always important to be very clear when you're giving your instructions. So take a deep breath in for me, and all the way out, and hold it there. So don't just say, can you hold your breath for me? Alright? We'll go back to the murmurs. The ones you're going to get in terms of murmurs are aortic stenosis and mitral regurgitation. It's most likely you'll get a systolic murmur in your examination. Okay? And the difference, imagine you're trying to like shoot a spitball or something, okay, through a straw. You're hearing blood in aortic stenosis. You're hearing blood shoot out of a stiff valve. Okay, so it doesn't last. So you get lub, dub. Okay, it doesn't last all the way through. It's just that you're hearing that sharp exiting of blood. Whereas mitral regurgitation happens throughout systole. Okay, and it's a mid systolic murmur, and it lasts throughout. So you might not hear the second heart sound. Okay, so do you guys have time, or do you want me to explain murmurs a little bit more, or shall I? Is everyone happy with them?
Sorry, you know, mitral regurgitation, isn't that
Pansystolic. What did I say?
systolic?
I'm sorry. Yeah, pansystolic. So, yeah, sorry. Pansystolic and ejection systolic. Okay.
A good way to like sort it out in your head is if you just get your own stethoscope,
Go on.
put it in your ears and hold the diaphragm in your hand. And for a pansystolic murmur, draw a little circle on your hand. Whereas like aortic stenosis, just a straight line. If you do it, it just sounds exactly like that basically.
So you take your diaphragm with your stethoscope, put it in your hand. Does anyone have a stethoscope with them? Try it now.
Do you guys just carry stethoscopes around with you? Like,
Yeah. Okay, everyone ready? So pop your stethoscope in. Hold the diaphragm in your hand, like that. Close your hand. Take on the back of your hand with your index finger. Just make it do a straight line like that.
you have to press quite hard.
Squeeze the diaphragm quite hard. Okay? That is an ejection systolic murmur. Now compare it to making a C shape. It's a C, okay? Do you hear the difference?
What's the C shape?
Pansystolic. Did you feel a difference or not really? Yeah? Hands up if you didn't. Okay, fine. Is everyone clear that the first heart sound is your mitral and tricuspid valves closing, and your second heart sound is your aortic and pulmonary valves closing? Is everyone clear about that? Okay, so it takes a little bit of time to get your head around it, but if you think, okay, that's why the whole time you need to be feeling the carotids, because you need to know which sound is the first set of valves closing and which is the second. The mitral and tricuspid valves will be the first heart sound, so they'll correspond with a pulse. So if you hear the sound at the same time as you feel that pulse, that's your first heart sound. So is it happening after that and before that? That's how you can time the murmur. And it takes a lot of practice to get your head around it. Is it happening between the two? What does that mean? Okay, and is it happening at the beginning or the end? And the best way, or throughout, sorry. The best way to do that is practice on patients. Go and ask, can I hear an ejection systolic murmur? Go on YouTube, go on whatever. So in your exam it will be bar and door. Okay? It will probably be enough to say I heard a systolic murmur. Okay? And my differentials are aortic stenosis or mitral regurgitation. Okay? But practice on patients so you can actually hear it. Or on your hand. done that. We've listened to the carotids because aortic stenosis radiates to the carotids. And why did I listen to his back? Very good. Yeah, lung bases for crepitations as a sign of right-sided heart failure. What's the pathology that I'm listening for? Pulmonary edema. Very good. For left-sided heart failure. Left-sided heart failure. Cheers. And then again, peripheral edema. Yes.
So just one thing on the slide before.
Yeah.
When you listen to Jessica, did you listen with the diaphragm and the bell? Which one is it?
It is the bell. Mostly because you can't actually really fit a diaphragm on someone's neck.
Not because of the nature of the sound. But like Jack said, on him I could fit my whole diaphragm. Peripheral edema we went through last week, and I checked for sacral edema as well. And then we present. Did anyone write a blurb for presentation of a normal cardiovascular examination? No? Anyone brave enough to have a go? At normal? Completely normal? No? Did you say yes? No? Okay. Fine. So, here's one I prepared earlier. Thank you for letting me examine Mr. Jack Faulkner, a 60-year-old or wherever, a 25-year-old gentleman who appeared calm and comfortable at rest. On examination, his pulse was at a rate of 72 beats per minute and was at a normal rhythm and character. There were no peripheral stigmata of cardiovascular disease in the hands, face or chest, with no palpable heaves or thrills, and heart sounds 1 and 2 were heard with no added heart sounds. There was no sign of any cardiovascular compromise or fluid overload. In summary, this was a normal cardiovascular examination. Okay. Example 2 is Rambo style, that we talked about last time, for aortic stenosis, for example. Thank you for letting me examine Mr. Jack Faulkner, a 60-year-old man who, on examination, showed signs of consistent with a diagnosis of aortic stenosis. This is evidenced by a narrow pulse pressure of 120 over 100 and a loud, harsh ejection systolic murmur, heard loudest in the second intercostal space on the right side, parasternally, that radiated to the carotids. There were no added heart sounds and no palpable thrill, so I'm giving significant negatives as well. There were no signs of heart failure or cardiac compromise, with the patient's heart rate of 72 beats per minute. In summary, this is a 60-year-old gentleman with an apparent diagnosis of aortic stenosis, with a differential diagnosis for the systolic murmur being mitral regurgitation. Does that make sense? So you give your differentials for 2 systolic murmurs. What's this? This is mitral regurgitation. Oh, this is a metallic heart valve. Okay, so giving positives and negatives for the complications. So thank you for letting me. Do you want me to keep reading, or are you happy? Yeah. Thank you for letting me examine Mr. Jack Faulkner, a 60-year-old gentleman who appeared calm and comfortable at rest, with a heart rate of 60 beats per minute and a blood pressure of 120 over 80. On examination, this patient showed signs consistent with a metallic heart valve that was functioning well. This was evidenced by a midline stenotomy scar with no other visible scars seen, and a metallic click heard from the end of the bed. The patient had a loud heart-first sound. So you might not hear him, it's not metallic in nature, but it'd be really booming. It'd be louder than any other first heart sound you've heard. Okay, it's like boom, duck, boom, duck, boom, okay. The patient had a loud first heart sound, heard loudest over the 5th intercostal space mid-clavicular line that did not radiate, with no added heart sounds. The patient also showed some bruising across the patient's arms, but no active bleeding. A warfarin yellow book was also seen by the patient's bedside. There were no signs of infective endocarditis, anemia, or cardiovascular compromise. In summary, this gentleman shows signs of having a metallic mitral valve replacement. Okay? So you're always, that's why I said an inspection, you're looking for all the different complications. You're looking for the signs so that you can fit them into your blurb. And we were talking about this earlier, and Jack said it. When you're onto the back, okay, if they don't look like they're fluid overloaded, and you're coming to listen to the chest, you should have, it's like, okay, it's got to be one of 2. I'm either listening for that heart sound, or I'm listening for that murmur. I've already got a suspicion of what it's going to be, because of their blood pressure, because of what's around the bedside, because I've looked at their face, because they might have other signs, okay? So it's like, come on. Boom, I've heard it. And then everything after that is academic, because you know what you're doing, you know what you found, and you're onto the back, and now I'm just thinking about my blurb, thinking about my presentation. I'm in autopilot, lean back, I'm going to feel your legs, don't care, I'm just getting it ready in my head, okay? And then you turn around, hands behind your back, and you fire, and you don't look back. Literally don't look back. Then go, thank you for letting me examine Mr. What's your name again? Like, so many times that's happened, like, yeah, that's right, Mr. whatever, and he's how old is he then? 60, okay, fine. Don't ever speak to the patient again after the examination. That part is over. Okay, it doesn't look good. If you can't remember, thank you for letting me examine this gentleman who appeared calm and comfortable at rest. Okay? So what do you mean you don't know how old he is? I asked him at the beginning, you should have been listening. Alright? So don't worry about that. Alright? If you can't remember, don't and ah. Just sound as slick as possible. Because in your head, you know roughly how old he is. He's an elderly gentleman. You can say an elderly gentleman, this young gentleman. Alright? Thank you guys for the feedback last week. It was really, really helpful. I hope I tried to address some of the points you guys brought up. I've got the link on this presentation.